Good evening, everybody. Thank you for joining us tonight. I'm Hannah Collins, and we're here with Dr. Reeve discussing PADs. I'm going to go ahead and introduce Dr. Reeve, and then he'll get started on his presentation. Dr. Reeve is a native from Carroll County, and he graduated from Carrollton High School. He attended the University of Georgia to study his undergrad and then continued his education at Mercer University for medical school. Dr. Reeve completed his general surgery residency at Wake Forest University in Winston-Salem, North Carolina. While there, he also completed a master's degree. Dr. Reeve recently completed his vascular surgery fellowship at Emory University in Atlanta prior to joining Tanner Vascular this year. I'll give it to Dr. Reeve to go ahead and get started.
All right, thank you, Hannah. I appreciate that. Thank you all for taking the time to join this presentation tonight, and hopefully I won't bore you too much. But I think the important thing is just to bring up an issue that is probably underdiagnosed, and I think this is just a good way to kind of get out and reach out and kind of just provide some information, and hopefully there's someone out there, someone out there that this may ultimately help or strike home to. So as Hannah said, I'm Dr. Reeve, one of the newest Tanner vascular surgeons, and we'll talk about peripheral vascular disease, or peripheral arterial disease, or PAD, is commonly I may kind of interchangeably use those. Here's the tab for the questions. This will the opportunity. It's any time that if anyone has a question, you can click on this little box, and your name is completely optional, but ask the question, and if not, you can use this little Q&A box in the top right corner, and that way hopefully at the end I'll be able to answer all your questions. So we'll kind of go over briefly what we're going to discuss, and really I think starting out just what is peripheral arterial disease, or PAD, and kind of its prevalence in our community. We'll talk about risk factors, as well as what are the symptoms that people with peripheral vascular disease experience. And then I think how do you diagnose it? And then probably most importantly is what is the treatment options, and try to delve into that just a little bit without going in too deep, and then kind of briefly touch on some of the prevention strategies that we do have. So what is peripheral arterial disease, or you'll commonly hear PAD, or peripheral vascular disease? I think they all are interchangeable, but essentially it's just this narrowing, or you can even get blockage of the arteries. And when we talk about peripheral arterial disease, we're primarily talking about those arteries that go down to the legs. So essentially you'll hear people that have vascular disease and other aspects commonly in the blood vessels in the heart. But for this aspect, we're primarily talking about, when we talk about peripheral artery disease, most people are usually referring to artery disease that occurs down in the two main blood vessels that really supply both legs. And really what it is over time you get a buildup of fatty plaque, which essentially develops within the wall of the artery, which is also known as atherosclerosis. And this is a common thing that that occurs really with aging. As we kind of get older and our diets and things like that, we all probably have some of this buildup of plaque that develops in the artery wall. But it really, the difference and the importance is, does it progress enough to cause symptoms? And that's really kind of what dictates the decision to do any sort of a treatment, which we'll go into in just a little bit. So here's just a little bit of a picture here. You can see kind of these normal arteries here, and over time, over age, after diets and things like this, we start to develop plaque that develops within the wall. And if this progresses, two things: it can progress slowly enough that it impedes the flow of blood through the lumen, or through the middle of the artery. And the other issue with this is you can have plaque that actually breaks off, and that can break off and go downstream and cause some sort of a acute, or kind of all of a sudden blockage in one of the blood vessels, which can be something that needs to be addressed quite quickly. So just kind of in a general overview of PAD, it really is a significant global problem, not just a problem here in the U.S., but it's primarily a problem of those that are getting older, and I'll show you a chart here in just a bit. But it is quite rare in children and really young adults. But as we age, this is certainly a much more common disease that affects a number of different people. It's really more common in those patients that have a history of diabetes, a history of smoking, high blood pressure, as well as high cholesterol. So really things that we commonly see, and these are all also commonly seen in patients as they progress in age, and so they all kind of are all associated with each other. When you're looking at worldwide, there's probably over 200 million people that are affected with peripheral arterial disease. This is probably even higher in those patients that have some disease that's yet to really manifest itself with symptoms. And so I suspect that number is probably even higher. And it's not just in underdeveloped countries or third world countries, but this is very commonly occurred in developed countries as well. This is just a chart that I think really highlights the importance that aging has on the prevalence of peripheral vascular disease. As you can see, it's the overall prevalence in males and females is quite low in those less than 50. And as we continue to age and grow older, it significantly increases. When you're looking at, over a fourth of 1 in 4 people, males over the age of 80 have a history of peripheral vascular disease. So as you can see, this is much more common as we get older. So what are the risk factors? One, as we've already mentioned, age. That's probably one of the strongest, quite common. Up to about 25% of the patients 80 years and older likely have some component of peripheral vascular disease or peripheral arterial disease. Whether they're symptomatic or not is kind of is a different thing, but there's certainly a high percentage of these that are. We look at race. There is some studies that show a higher incidence as well as worse outcomes in African Americans, and they also looked at, they factored in things like diabetes and high blood pressure, and BMI are kind of a sign of kind of a marker of weight to somewhat, and it wasn't really explained by that. So there's some other things that may cause some higher incidence and poor outcomes in this particular population. But really we need to look into that further before we know. I think this is probably not a surprise, but smoking has a significantly increased odds of developing peripheral vascular disease, and probably those that smoke, the likelihood and the risk of developing certainly symptoms at an earlier age is much higher in those that are smoking. And there's been studies that show even secondhand smoke carries some risk for developing peripheral arterial disease. So not just firsthand smoking, but also secondhand. Again, diabetes, as I mentioned earlier, is very similar to smoking, and really the combination of smoking and diabetes probably puts individuals at the highest risk for developing peripheral arterial disease, amputation, and even death. So the combination of those certainly put that subset of patients at a much higher risk for developing peripheral arterial disease, and not only that, but having really kind of what I would say more advanced disease and higher risk of long-term complications. And high blood pressure, again, not as strong as smoking and diabetes, but certainly a risk factor for peripheral vascular disease. Not surprising, high cholesterol and obesity, which I think these kind of go a little bit hand in hand, but there's the patients are more likely when they have this metabolic syndrome, which is associated with obesity, high blood pressure, elevated triglycerides, and diabetes. All of those kind of factored in, it places people at a higher risk for developing peripheral arterial disease. And there is some research out there about genetics, maybe that peripheral arterial disease is more common among families. However, the pinpointing a definitive gene is probably a little bit harder and not as a direct, not as a specific link, other than we know that it's probably more common in families. So how does peripheral arterial disease progress? And I think this is a really important slide because this really highlights, we talk about there's a lot of people that have peripheral vascular disease or PAD, but not everybody's symptomatic. And I think that really drives our decision making regarding any sort of treatment. There's a number of people that really have no symptoms, and they have some plaque buildup in their arteries, but it's not significant enough to really cause any significant symptoms in their legs. I think as this progresses, people may often get pain with walking, and this is a really important thing that I think highlights really one of the kind of sets peripheral vascular disease and pain in the legs aside from maybe other causes, maybe from a nerve impingement or a vein problem or something that's maybe not associated per se with the arteries. But patients usually describe this walking, and as they walk a certain distance, they start to get cramping, whether in their thighs or their calves, and they have to stop. With rest, this usually gets better, and then they're able to walk again. This is usually classic, what we call claudication, and it's really kind of the early progression of peripheral vascular disease. As this progresses even more, patients will get pain at rest, where it's not even associated with their walking, but really they can just be sitting and pretty much have pain all the time. And I think the pain at rest and to wounds is maybe that's not so much of a progression. Those kind of can sometimes go hand in hand, but sometimes patients, the vascular disease can get so bad that wounds develop, and they're very difficult to heal when there's not enough blood flow to provide all the nutrients and things they need to get those healed. So let's just jump in just a little bit into asymptomatic disease, and this is probably the majority of the people, and then this is the majority of the people that we as the vascular surgeons don't see, the people that are out and doing their normal things and taking care of their normal business. They're not having symptoms and therefore are not referred to us, and really they just have this low burden of disease. They may have some significant blockage, but they've got enough kind of collateral blood flow or blood flow that gets around that to be able to compensate, and therefore they don't have symptoms. And I think that there's another group of people that their activity may be limited, their disease may be more advanced, that however their activity level is limited, that they don't develop that pain with walking because they're very minimally ambulatory or very minimally walking, or maybe they're limited with their walking because of more of a shortness of breath and a respiratory problem, and that stops them before their legs do. So I think that there's some a little bit of a spectrum in those that have asymptomatic disease. However, I think it's important to highlight this group because there's still a risk for some sort of cardiovascular complications and risk, as well as mortality. There's studies have shown up to about a greater than a 2.5-fold risk of death, and even a higher risk, up to 5.5-fold risk of some sort of a coronary artery disease related death. So we know that even those patients that are symptomatic, it's important to identify those and get them on the appropriate medical therapy, because there still is a risk for cardiovascular complications down the road. So then we progress to, again, the claudication, and this is the pain with walking that I discussed earlier. Again, this is the pain that's usually brought on by exercise. Patients say that they're able to walk a certain distance, and then they start get cramping, whether it's in their calves or in their buttock area or in their thighs, and they usually stop. This pain improves, and then they're able to continue walking again. Again, this is just kind of sort of that progression that we see with peripheral vascular disease, and essentially it boils down to, when you're walking, your muscles require that oxygen and the blood flow that they need, but there's enough of a blockage there that when they need the extra blood flow for the muscles to walk, to pump and to function, the body is not able to keep up with that, and that's really kind of the basis behind claudication. And this can be progressive. You can have patients that are able to say, well, I can walk a mile, and then I on the treadmill, and then I notice that I have to stop, and then it gets to a point where that sometimes that gets shorter and shorter. So over a 5-year period, about a fifth of the patients with claudication will experience some sort of a major cardiovascular event, whether this is a heart attack, a stroke, or even death, which the risk of death over 5 years is up to about 15% or so. Again, the risk of amputation with patients with just pain with ambulation is very low, probably less 1% or less yearly, but it's not really the limb loss or the amputation risk, it's the other cardiovascular risks that are associated subsequently with those patients that also have peripheral arterial disease. So then we progress to even a more severe form of peripheral arterial disease. And this is when patients really have pain at rest or even develop wounds or non-healing wounds. And oftentimes you'll see some redness and some erythema of the feet and toes. Sometimes patients will say that they hang their feet over the side of the bed, and that's really the only thing that helps relieve their pain, and that's really just the dependent nature allows some, with the help of gravity, some extra blood flow to get down there, and some patients will describe that they sleep with one leg hanging off the bed, and that's usually a sign that they've got some pretty moderate to severe peripheral vascular disease. Sometimes you'll notice there's very little hair that's on the toes or even the lower legs, and sometimes this can be a sign of peripheral arterial disease. And then you get the small wounds or sores, especially those that have been present for weeks to months and they just won't heal, and despite antibiotics and wound care and things like that. And those are ones that there's likely an underlying, not always, but there's likely an underlying vascular problem, and there's not enough blood flow to get that wound to heal. Sometimes we call this pain at rest or wounds critical limb-threatening ischemia. I apologize, I've spelled ischemia wrong, but there is, this is described as this critical limb-threatening ischemia that can develop with patients that have pain at rest or wounds. And these patients are really at the highest risk for some sort of a cardiovascular event, and that is a heart attack, a stroke, an amputation, or death. When you're looking at about 1 year risk of death in this group with this really what I would say advanced peripheral vascular disease, the risk of death is close to 22% or so. And this group is the ones that did not undergo any sort of an intervention. The risk of amputation at a year is about a quarter in these as well. So these are the ones that were much more aggressive as far as our treatment. And so when we look at predictors of amputation and death, those that are over the age of 75 are at a much higher risk for amputation and death in these patients that have this advanced form of peripheral arterial disease. Also, those patients with kidney failure, with coronary artery disease, with a history of heart failure and diabetes, those with dementia, BMI is a factor in there, as well as those that have been deemed frailty based on some sort of a frailty score. So how do we diagnose peripheral arterial disease? So I think first we start out with the non-invasive imaging, and these really, I would probably say this first, the ankle brachial index should really be the first objective measure that should be used in diagnosing these, and whether they're done in the office, in a clinic setting, they can be done in the hospital, they can be done by a vascular lab, or they can just be done by a nurse or physician that's trained to do those. But we put a cutoff of 0.9 is kind of our indicator of peripheral vascular disease. So those with a ABI of less than 0.9 would indicate they have some sort of peripheral vascular disease. We look at the next kind of step in the non-invasive imaging, CT. I would say this is probably not the best kind of go-to as far as imaging, and it's really probably should be reserved for vascular surgeons as they're kind of making their decision as far as operative planning. But it can be a little bit more expensive, and it does require contrast with, again, people that may have kidney disease or allergies to contrast should really try to be avoided in this group. I I think one that I missed and did not include on here is an ultrasound, which we commonly perform in our clinic, but that's a good non-invasive, doesn't require any contrast, and is a good indicator that we're able to scan the entire arterial tree down the leg and try to identify whether there's a significant narrowing or blockage. And that's really beneficial as we make a decision regarding some sort of a treatment. Look at invasive imaging, arteriogram, and this is where we take patients to the operating room or the cath lab and place a small IV, usually in the artery into the groin, and actually take pictures of the leg. And that way, this gives us really probably the best technique to diagnose and identify narrowing and areas of blockage in the arteries in the leg. Probably the biggest benefit of this is not only is it diagnostic, but it can also be therapeutic. And at the same time, we may be able to treat this area with a balloon or a stent. I would say the downside of this is it is a procedure, and it does have its risk and does require to be taken to some sort of either the operating room or the cath lab. So we talk about treatment. This is important to look at, how do we treat peripheral vascular disease? And I think it's important to start out with the non-surgical or the non-operative ways that we treat peripheral arterial disease. I would say the first thing is, and probably the most important, is risk factor modification. And I think that starts with number one, in those patients that smoke, tobacco cessation. It's extremely important, and we've talked about the significant risk that tobacco abuse carries with patients that have peripheral vascular disease. I think the management of not only of the other comorbidities, including high blood pressure, high cholesterol, as well as diabetes. Those are very important as far as trying to mitigate these risk factors and try to decrease the progression of the disease. So when we look at other non-surgical treatments, and this is primarily looking at claudication again, those patients that are on the early spectrum of having symptoms when they walk. There's been a number of studies that have showed improvement in pain-free ambulation and overall walking performance in those that undergo some sort of exercise therapy. It also has been shown to decrease the cardiovascular risk by lowering cholesterol, helping with blood pressure, and improving diabetes control. And the recommendations usually are about walking about 30 to 45 minutes up to 3 to 4 times weekly for at least about 12 weeks. And the recommendations are walk until the pain, until the onset of the pain, and then stop, a short rest, which usually allows the pain to subside, and then return to exercise. And this is what I try to talk to people that see me that have pain in their legs with ambulation and this claudication type symptoms. I really start by trying to encourage them to walk. Sometimes they say, well, is that going to make anything worse? And it actually will make things better. So patients that can come up with some sort of a regimen to walk at least 30 minutes a day for 3 to 4 times a week will over time can have some benefit and actually get to where they're walking a little bit further. So then when we look at medical therapy for this is for claudication. There's 2 medications that have been approved by the FDA, pentoxifylline as well as silastazol. And really, when they went head to head, silastazol was the better of the 2, which sometimes is called Pletol. And what it does is it inhibits the blood vessels from tightening up and actually kind of helps to keep these dilated and open a little bit. There's also some, they've looked into it, and there's some benefit as far as decreasing triglycerides, although the mechanism of that is not entirely understood. But it is shown to improve walking distance in patients with claudications, with claudication. I think the big side effects, although not entirely common, but they can happen, are headaches and some GI issues. The one thing, this is contraindicated in patients that have a history of heart failure. So this is one of the unfortunately, only one of the medications that we have to treat claudication. There's just really not a lot out there. So in addition to the walking-based measures and getting out and exercising, the silastazole is really the only medication that's been approved. So then, what's our decision as far as surgical treatment and kind of taking that next step? And as I mentioned before, it really is dependent on the patient's symptoms. I think as I've gone over, I think you can have peripheral vascular disease, and people say, well, I have vascular disease, but I don't really have any pain, and I wouldn't know it if no one told me. And those are the people that I would not recommend surgery, at least as a first line. And I think that's when you look into kind of the risk factor modifications and exercising and walking and those kind of things. So when we think about surgical treatment, again, with claudication, with the pain with ambulation, we usually start out with non-operative management and really, again, working on this risk factor modification and getting people out and walking. However, in those patients that have pain at rest or wounds or non-healing ulcers or things like that, kind of that next step in the spectrum of peripheral arterial disease, we're a little bit more aggressive because, as I've mentioned before, their outcomes not only with losing a limb and an amputation rate, but also their cardiovascular risk is much higher, and I think we have to be much more aggressive when it comes to those. So the two real options that we have primarily are what you'll hear endovascular or open surgery. And I'll start with the open surgery. That's kind of the tried and true, the historical method that we've used. And that may involve actually going down and cutting out the plaque and removing it from the artery. Again, this is really best served in certain areas, primarily in the groin. If there's a focal area of plaque that's in the groin, if you have a long segment of plaque, that's hard to clean all of that out without making a significant incision in the leg. So that's usually reserved for those that have some sort of a focal plaque or blockage. And then the other option is a bypass, which is essentially rerouting. So usually trying to use the patient's vein or using some sort of a prosthetic tubing that essentially goes around the area that's blocked to provide blood flow further down the leg. These surgeries can be anywhere from couple hours to 4 or 5 hours, and they almost all require general anesthesia. The recovery time is a little bit longer, usually require some sort of hospitalization anywhere from 1 to 2 days to up to a week or so. And certainly there's more stress on the body. In patients that have other medical, significant other medical history, then this can be a little bit more higher risk. And so we look at the other side of it is the endovascular, and this is what's become a little bit more common over the years. And this, again, this is when I talked about we would access or put kind of a little catheter into the artery or the vein, just in the artery, usually in the groin, and this involves using wires and catheters and trying to get across these areas that are blocked and using a balloon or a stent to try to open up this area of narrowing in the artery, or even opening up if there's a complete blockage, trying to get that opened up. Usually this can be done without general anesthesia, usually with just a little bit of sedating medicine as well as some numbing medicine around where we make the puncture. And most people, depending on what we do, risk are probably a little bit lower, and patients usually most often will go home that same day. So again, this is another good option, especially in people that have significant medical history, and not are always people a candidate for endovascular. I think really extensive disease would probably preclude people from being a candidate for endovascular therapy. So I think, kind of going back over some of this for claudication, again, after we've tried usually medical management and walking and things, depending on the anatomy, we'll try an endovascular intervention first, because again, that's a little bit more low risk, and these patients along the spectrum of arterial disease, have not progressed so severe, but we're just trying to get them some improvement in their walking distance and things like that. Again, it's significantly, the anatomy is very important on whether we're able to do this in an endovascular fashion. And then those patients that have critical limb-threatening ischemia, those with pain at rest or wounds, usually, again, when you look at surgery or medical therapy, surgery certainly outweighs, is more important and much more aggressive in this patient population. I think when you look at whether endovascular or open surgery, I think oftentimes we will, if there's an option for endovascular therapy, we will often try that first. Again, it all depends on kind of the anatomy, and sometimes those are things we don't know until we actually get in there and take some pictures and get some more information. But I think anatomy, how fit is the patient for a surgery? If they're too high risk for a big open bypass surgery, then you really kind of rely on an endovascular approach, and we usually can get pretty aggressive in trying to get some improvement in blood flow. And then also, I think you have to look at, if there's going to be a bypass, some sort of a conduit for the bypass, whether that's the patient has a vein that we can use. When we do these bypasses, the veins have a better patency than the prosthetic tube grafts that we use, and so sometimes that can make a decision on what we use. So just briefly looking at primary prevention, again, how do we, patients say, well, I don't know or have vascular disease that I'm aware of, but what can I do to prevent it? And I think it all really revolves around risk factor modification, and that involves, for those people that smoke, really trying to decrease and even stop the smoking. Is just really very detrimental to the arteries, and over time it is just going to continue to be problems, and certainly will progress. I think trying to get out and exercise, and good to be active and as much as you can, and even with those patients that do have some mild vascular disease, exercise is very good, and that kind of trains the body to almost kind of become accustomed to the blood flow that it has, and gets to where the patients are able to walk a little bit further. I think management of cholesterol and diabetes and high blood pressure kind of all go into one. Again, those are just trying to keep all of those in good control. Diet, watching what we eat, and making sure that diabetes and sugars are under control, and keeping a close watch on those. So just lastly, the screening for peripheral arterial disease, there's not strong guidelines as far as the screening. We don't have any strong evidence to support widespread screening. I think in those patients that are considered high risk, as we've talked about, whether other comorbidities and age, then it's probably a good idea to do some sort of a screening. Excuse me, especially those that are 70 years old and diabetic. I think that's a appropriate group to screen with probably just an ankle brachial index. There were some old guidelines from the American Heart Association in 2016 about testing with ABIs in asymptomatic patients that had risk factors. Those patients older than 65, or those that were less than 65 that had some sort of known atherosclerosis or elevated cholesterol, and in those that were older than 50 with any sort of diabetes plus any other risk factor. And I think any patient that has any known history of coronary artery disease and cerebrovascular disease, those can all be kind of encompassed, that this is a part, essentially a part of all the same global process that's going on. And I think those patients would benefit from screening. That's all that I have. Hope that wasn't too painful, but happy to answer any questions if anyone has anything. So thank you.
Dr. Reeve, you did have a couple of questions. One of them was, can you tell a difference between a regular sore and a sore I might have with PAD?
Yes, I mean, again, there's a number of different sores that can develop, and it gets complicated because there's some sores that happened around the malleolus, which is those two round portions around the ankle on the inside and on the outside. And those sometimes you can get wounds there, and sometimes those can be a different etiology. Sometimes they're a vein problem, but we also treat the vein issues too. So sometimes those are good to be referred over to see us, and we can make that decision. Oftentimes, you'll see wounds on the toes, and I think probably the most common is they have a wound that has been present for several weeks, and they've seen their physician or someone, and they've prescribed antibiotics, and it just really hasn't healed up like it should. Sometimes we'll see patients that have seen a podiatrist, and they've had a nail trimmed, and maybe there was a little cut or something during that, and that wound just hasn't quite healed up. And usually that's the sign that there's probably some underlying vascular disease, and if you've had this wound that really just won't heal. But again, it can be a little bit hard. That there's not really one specific type wound, but I'd say probably most commonly those that are slow to heal or fail to heal probably would benefit from some further evaluation to make sure there's not any vascular disease.
Okay, and another one that came through was, is there any way to tell if my quality of life will be heavily affected significantly? No, I mean, I think that's a very difficult thing, and I think that's what we have to weigh out, talking to patients, and whether their quality of life is affected by their pain in their legs, or they're limited with their ambulation, and would intervening on that, would that improve their quality of life as far as allowing them to get out to go to the grocery store, shop, or do things like that. It's hard to say who will benefit, because a lot of times I think it's more complicated, because there's probably some other underlying things that may not be vascular related that may be contributing to kind of the decline in generalized health. And so I think those are important things that we have to sit down with and talk with the patient to say, hey, what do you think is keeping you from doing the things that you enjoy? And if they say, it's just my legs, if I could get these where they were not hurting so bad, or and I was still able to go shop or go around the mall or do things like that, then I think that those are the folks that say, I think that there may be a benefit for us to try to do something. But to pinpoint and say who will benefit exactly and whose quality of life, I think that's probably, it's just more complex than kind of a simple question. Okay, and your last question that came through was, are you and your practice taking new patients?
Absolutely. Yeah. So we're seeing my partners, Dr. Whitney and Dr. Park, as well as myself. We see new patients, and I think sometimes it's good to start with some of the screening with the primary physician, or but the primary physicians are very, I think, very amenable to saying, hey, absolutely, I'll send you over. And I think it's good for us to, sometimes it can be very difficult to sort out leg pain, whether it's a vascular problem or some sort of because there's other reasons that patients develop leg pain. And so, just like there's other reasons that patients can have wounds. And so I think it's important for us to say, I have kind of the mindset, and I think my partners do as well, that we're happy to see anybody who has that issue, and probably let us sort it out, because I think that we can probably look into it and make a decision, and that's probably the best way. But yeah, absolutely, we're seeing new patients.
All right, well, that was all the questions that came through. I just wanted to say thank you all for joining us tonight, and to please continue to check out our classes on tanner.org, classes and events, for other informative topics that are starting to come up in 2021. And we hope you all have a wonderful evening. Thank you, Dr. Reeve, for joining us tonight.
And thank you all. I appreciate you taking the time to listen.